Antipsychotic drugs, I think, can be useful. I think when someone's very psychotic, very distressed, trapped in a sort of internal world, they can sometimes be useful in dampening that down. What I've been trying to say about antipsychotics for a long time, and indeed about all drugs that are used in mental health, is that they don't rectify a chemical imbalance, they don't cure an underlying disease, they don't target some underlying biological abnormality as they are often presented as doing. So I think that's the most important thing for people to understand, that these drugs are not targeting an underlying disease or abnormality in a very sophisticated way. What they are doing is altering the brain and altering people's behaviour and people's thinking and emotion through altering the brain. So antipsychotics undoubtedly make people quieter and more placid, and sometimes that can be helpful. Sometimes it's perceived as helpful by the person who takes them, sometimes it's perceived as helpful by other people around them who don't like their previous behaviour. So they have effects, but whether they're useful effects or not depends on the context. And of course they also have lots of serious adverse effects, and any benefits they might have need to be balanced against those adverse effects. So antipsychotics, I think, can be useful for the symptoms of psychosis in particular, but they're not targeting those. They're not targeting psychotic thoughts in general. Antipsychotics slow down all thinking processes, and they reduce and restrict people's physical activity as well. And those effects can be useful, but that is not the same as curing or reversing an underlying disease. So in the short term, antipsychotics, because they have this effect of sort of slowing people down, dampening down people's emotions, restricting their movement, can be experienced as very, very unpleasant to take. So I think one of the most important short-term side effects is they're just not very nice. And they also have other side effects. They can produce neurological, some of them produce neurological, acute neurological crises when people sort of stiffen up all over and can't breathe properly. They can also produce this unpleasant effect called akathisia, where people get very restless. They can make people sort of stiff and slow. But I think one of the things that we need to acknowledge is that they're just really not very nice to take for most people. They also have sexual side effects. They cause impotence and reduced sex drive and the whole range of sexual impairment. So there's some evidence that if people are on antipsychotics long term for a condition like recurrent psychosis or schizophrenia, as we might call it, that when they stop taking antipsychotics, that increases their risk of having a relapse, possibly because the antipsychotics themselves make a psychotic relapse more likely. There are some case studies of people who've taken antipsychotics who've never had a diagnosis of psychosis, and when they've stopped taking them have had a psychotic episode. It may be that this is to do with the fact that most antipsychotics block dopamine receptors, and therefore the brain manufactures more dopamine receptors, and when you stop taking the drugs you've therefore got an overactivity of dopamine and probably of other brain chemicals as well that many of the drugs affect. And these effects may be what causes the psychosis when people stop taking the medication. So about 10 years ago or a bit more, antipsychotics were being widely promoted and widely held as, especially the new antipsychotics, as being, really new miraculous treatments, and they were being advertised for use in children, for example. And I think there's been a bit of a sea change over the last decade and a half, and that has partly been because it has become apparent that the pharmaceutical industry have been marketing these drugs to people with conditions that the drugs have never been tested in, so the drugs are not licensed for those conditions. And it's also become apparent that the pharmaceutical industry have tried to cover up, or at least to minimise, the adverse effects that these drugs can cause. So one of the best known examples was that Eli Lilly tried to minimise the weight-inducing and diabetes-inducing effect of its antipsychotic drug olanzapine. And this was revealed because some confidential papers were revealed during a court case. And those showed how Eli Lilly had gone about trying to reduce the impact of the knowledge that olanzapine was linked to weight increase in diabetes. So for a long time, people have believed, or psychiatrists have believed, I should say, that schizophrenia is either caused by a brain abnormality or that chronic schizophrenia causes progressive brain abnormalities. And when I was learning psychiatry, we were shown pictures of scans of people's brains who were diagnosed with schizophrenia and so-called normal people to show that the brains of people with schizophrenia were smaller and they had larger brain cavities than comparable control people. And this was accepted for many years. It turns out over recent years there's been increasing evidence that long-term treatment with antipsychotics is what is reducing brain volume and therefore probably increasing the size of the brain cavities as well. So that evidence has come from studies that have followed people up on the drug treatment and shown that there's a strong correlation between the amount of exposure people have had to antipsychotics and the reduction in their brain volume. But it also comes from animal studies. There's been a study of macaque monkeys and a study in rats that have both shown that long-term antipsychotic treatment is associated with brain volume reduction. And these studies have been done very carefully. They've not been studies where the animals have just been given very high doses of medication, which used to be the case in some animal studies. They are studies where the doses have been carefully contrived to be comparable to the sort of doses that human patients are prescribed. And these studies show that there is brain volume reduction with antipsychotics compared to a placebo injection. So antipsychotics are not the most frequently prescribed medication for mental health problems. That would be antidepressants and also anxiolytic drugs like the benzodiazepines. But antipsychotics have been big sellers because new antipsychotics have been produced over the last few years. They've been on patent, they've been very expensive, they've been widely marketed. And so antipsychotics have been up among the most profitable drugs, the drugs that cost the public health systems the most money and that people spend the most money on across Western societies over the last few years. So there's been an increase in the prescription of all sorts of drug treatments for mental health problems over the last couple of decades, and the increase in the prescription of antipsychotics from the end of the 90s to about 2010 was 68%. So prescribing went up by about 2/3. We don't know exactly the reasons for that. I suspect it's partly because the indications for the new antipsychotics in particular have been widened. They've been promoted particularly for bipolar disorder, and the concept of bipolar disorder itself has been expanded so that more people would be considered suitable candidates for antipsychotic treatment than would have been in the past. So antipsychotic prescriptions are going up in adults and in children. We've got evidence of that. And the increase in children is due to a number of factors, they are given to children off licence with diagnoses of ADHD, behavioural disorders, autism, and then this new concept of paediatric bipolar disorder came about in the early noughties and was promoted by a group at Harvard University who were heavily funded by pharmaceutical companies, and a lot of their research was into paediatric bipolar disorder was funded by pharmaceutical companies. And they really came up with this idea of paediatric bipolar disorder, which was a vague and non-specific sort of concept which could easily be applied to all sorts of children with behaviour problems or children who were troubled for various reasons. So this concept created a very big potential market for children to take antipsychotics, and it was linked with the use of antipsychotics. So studies into the treatment of paediatric bipolar disorder investigated the use of various antipsychotic drugs. I don't think paediatric bipolar disorder ever took off to the same extent in the UK and Europe, but there is evidence that there's been an increase in the prescription of antipsychotic drugs to children there as well as in the US. So I'm not quite sure what the drugs are being prescribed for, or whether some children are being diagnosed with this condition there as well. Prescribing antipsychotics to children is even more concerning than prescribing them willy-nilly to the adult population, because it seems that their serious side effects are even more severe in children. So, for example, we know that antipsychotics cause weight gain in adults. They seem to cause 6 or 7 times the amount of weight gain in children. So children will put on 6 or 7 kilos over a period of a few months in some of the studies of antipsychotics. And we also know that they are more susceptible to the brain effects, to getting this neurological syndrome called tardive dyskinesia than adults are. So the prescription of antipsychotics to children is something that's very concerning. So the dopamine hypothesis of schizophrenia has been around since about the 1960s, and it came about because it was observed that haloperidol, that's one of the first drugs that was used for schizophrenia and psychosis, blocked dopamine receptors quite specifically and very strongly. And so people thought, okay, haloperidol is useful for people who have schizophrenia, therefore schizophrenia must be the opposite of what the haloperidol is doing. It must be that schizophrenia is an overactivity of dopamine. So there was this assumption already that what the drugs were doing was correcting an underlying disease, whereas there are other ways of understanding what the drugs might be doing. And there was a lot of interest in the dopamine hypothesis throughout the 1970s in particular, but no one could ever really find any hard and fast evidence that there were dopamine abnormalities in people with schizophrenia. They looked at dopamine metabolites in the urine, and some studies came up showing that they were increased in people with schizophrenia, and then they were replicated and it wasn't increased. And overall, if you put all those studies together, there's no difference in people, between people with a diagnosis of schizophrenia and people without. And then in the 80s, people got very excited because it was noticed that there was an increase in some of the dopamine receptors in the brain in people who had been diagnosed with schizophrenia. And people thought, now we've found the evidence for the dopamine hypothesis. But then it turned out that that increase was very strongly correlated with having been on antipsychotic drugs, and animal studies showed that antipsychotic drugs caused the brain to manufacture more dopamine receptors because they block the dopamine receptors that are there. So the dopamine receptor abnormalities were caused by people using antipsychotic drugs. There have been a few studies recently of looking at the uptake of a dopamine precursor molecule into the brain, and some of those suggest that uptake is increased in people who are acutely psychotic. The trouble with those studies is that they haven't controlled. We know that dopamine is associated with stress, with arousal, with movement, with lots of things that may well be associated with people being acutely psychotic. So they haven't controlled for those things. And also most of the studies are based on people who have used or are using antipsychotics, and so there's still probably a drug effect there. So to summarise, the dopamine hypothesis of schizophrenia has been around for a long time. It's never been conclusively proved. There are some people who think that it is right, that it's correct, that it has been demonstrated, but to my mind, the evidence remains very inconsistent and not enough for us to be able to conclude that there is a dopamine abnormality that is specific to schizophrenia or psychosis. When someone is acutely distressed, it is likely that their dopamine activity is increased, but we've got no evidence that that is specific to psychosis or schizophrenia. I've been interested as to why the dopamine hypothesis has lasted so long, because lots of other hypotheses about schizophrenia come and go. There's been a serotonin hypothesis, which was around in the 50s and 60s and then came back again for a while in the 90s. There's been a glutamate hypothesis, lots of other hypotheses about the origins of schizophrenia. But the dopamine hypothesis is the one that seems to hang on in there. And I think that is because it is linked to the effects of antipsychotics and because it helps to justify this idea that what antipsychotics are doing is treating an underlying disease. And that helps to distract people's attention from the very profound brain alterations that antipsychotics produce, and from the fact that that those alterations that they produce can be harmful and damaging and certainly very unpleasant. Over recent years, I would say that the psychiatric profession have become a little bit more cautious about the use of antipsychotics than they were, but they don't have a very good track record about being honest and open about the adverse effects. So tardive dyskinesia, which is this neurological complication of antipsychotics, was recorded back in the 1960s, but many psychiatrists spent time over the 1970s and 80s arguing that actually it wasn't to do with the drugs, it was to do with the underlying condition of schizophrenia, and they wrote lots and lots of papers highlighting the abnormal movements that people with schizophrenia have and saying this could be what tardive dyskinesia is, whereas actually it had been shown numerous times that there is this syndrome that's really quite distinct of abnormal movements that's related to antipsychotic use. Not only that, there is a lot of research showing that once you get these abnormal movements in tardive dyskinesia, they are associated with general cognitive impairment, with a decline in people's intellectual abilities. That's been shown in quite a lot of studies, but it's never highlighted as a part of the descriptions of tardive dyskinesia that get into textbooks. And again, I think psychiatrists should have been more aware of this and should have been more open about the fact that antipsychotics can cause this effect and exactly what this syndrome of tardive dyskinesia consists of. It's what's published in the journals really and what's talked about. So if you look at the literature on tardive dyskinesia, there are studies showing this association with cognitive impairment, but they never get followed up. It doesn't get into the textbooks. It doesn't get discussed in subsequent papers. And then there are all these papers trying to link tardive dyskinesia to schizophrenia as well. So I suppose it's just the sort of academic milieu of psychiatry has, I think, not really, for a long time it didn't really want to acknowledge that tardive dyskinesia existed, and it was a few psychiatrists that had to push the evidence and really make a point that this sometimes irreversible neurological syndrome had been linked to the drugs. So some psychiatrists did take this seriously and did really push the evidence forward, but many others, I think, just found it difficult to face the fact that these miracle drugs, that's how they had been taught about antipsychotics, that these miracle drugs had these, really serious consequences. The long-term use of antipsychotics is justified by numerous studies that have taken people who are on long-term treatment and transferred some of them to a placebo. And if you follow up people in those studies over a few months, the people who are transferred to placebo are more likely, considerably more likely, to have a relapse of their psychosis, or to have something that's considered to be a relapse. Now, the problem is that we know that when people stop medication, especially medication they've been on for a long time, that it takes a while for the body to adjust. There's usually some sort of withdrawal effect, some withdrawal symptoms, and so people could in fact be experiencing withdrawal symptoms that are mistaken for relapse. And very often relapse is defined very subjectively. It's defined as a change in behaviour or a sort of minor increase in symptoms. So it's likely that some of the relapses in those studies are due to the withdrawal symptoms of antipsychotics. There's also evidence that sometimes when people are undergoing antipsychotic withdrawal, they may have a relapse of their psychosis or an increase in their psychosis that has been precipitated by the withdrawal rather than the natural history of the condition. So, for example, when people have been on long-term lithium, people with bipolar disorder or what we used to call manic depression, there's good evidence that people's risk of having a relapse after they stop taking lithium is higher than it was before they started taking lithium. So there's something about the process of discontinuing a sedative drug, a drug that restricts and suppresses the nervous system that you've been on for a long time, that is a risk factor for having, usually in people with manic depression, a manic episode. So there is likely to be something similar going on with antipsychotics, that if you've been on these neurologically suppressant drugs for a long time and you suddenly stop them, that increases your risk of having an episode of psychosis. So the practice of long-term treatment for people who have psychosis or schizophrenia is based on these discontinuation studies, most of which stop the medication abruptly, follow people up for short periods, and just look at relapse, often in very subjective ways. There are 1 or 2 studies that have tried to take people off the medication slowly and follow people up for a longer period. There's just one study that's published that's done a really long-term follow-up of people who were discontinued from their antipsychotics in a gradual manner. And that study initially showed, like other studies, that there was a higher rate of relapse, usually mild relapses, in people who were randomised to have their antipsychotics reduced. But the 7-year follow-up results show that over the 7 years, the relapses equalise between the 2 groups. But more importantly, that after 7 years, the social functioning of people who'd been randomised to have the antipsychotic reduction was better, considerably better than the social functioning of people who were randomised to just carry on with their antipsychotics regardless. Now, there are problems with that study. It was quite a small study. People didn't stick to the randomised treatment rigidly, so some people who were randomised to maintenance came off their medication. Some people who were randomised to discontinuation didn't ever stop their medication, or stopped and then went back onto their medication. But nevertheless, it's a really important study because it's the only study that's randomised people, that's reduced medication gradually, and that's followed people up over a long period of time. And it seems to suggest that having a go at reducing and stopping people's medication is beneficial. It's beneficial in terms of functioning, and it doesn't, in the long run, increase people's risk of having a relapse. So I'm currently leading a project called the RADAR study, which stands for Research into Antipsychotic Discontinuation and Reduction. And we're trying to replicate that small study in a larger sample of people. And we're looking at we're randomising people either to maintenance treatment to stay on their current antipsychotic treatment, or to have a gradual reduction of antipsychotics. And we're looking at their outcome in terms of relapse rates, but also social functioning, quality of life, side effects, symptoms. And so hopefully that study will give us a lot more information about the pros and cons of trying to come off medication sensibly and gradually, even if you've been on it for a long time. Studies of antipsychotics given to volunteers suggest that they slow people down, but also that they reduce people's motivation and drive and create this sort of state of emotional indifference or emotional dampening, as well as making people sort of feel drowsy and a bit groggy. And this is what patients say as well, and they say it over and over again, that they feel slowed up, they feel that they can't think clearly, they feel that their personality has changed, they feel that they're not as interested or creative as they used to be, that they've lost some of their interest in life. And that's a very consistent view from patients. Now people who are really, really troubled by intrusive psychotic symptoms and thoughts, that might be a price worth paying. But for other people it won't be, and it is quite a high price to have your personality changed, your drive dampened in that way. So there was this myth around for a long time that antipsychotics had emptied the asylums, that we were able to shut the long-term mental hospitals because antipsychotics were curing people, and that people were basically just being given antipsychotics and returning to live completely normal lives. In fact, we know that the asylums shut down for political reasons. Institutional care was too expensive and no longer politically acceptable. Antipsychotics enabled that political decision to happen. They enabled politicians to be able to say to the public, look, we've got these wonderful new treatments now, we don't need these big old hospitals. So antipsychotics played a role, but not the role that they're said to have had. So psychiatrists have been promoting this idea for a long time, that antipsychotics shut down the mental hospitals. I think antipsychotics can have a beneficial effect in people who are acutely psychotic, and psychiatrists see that. What they maybe forget is that people with acute psychosis, most people with acute psychosis, will recover on their own. And so what the antipsychotics are probably doing in many cases is dampening down the symptoms until they fade away in their own time. But often that's interpreted as the antipsychotics having cured the psychosis. So if you follow up a group of people who've been diagnosed with schizophrenia or psychosis over a sort of 10 or 20 year period, you will find that the people who do best are the people who do not take long-term treatment. They might take treatment from time to time, but they're not the people who take it every day as is prescribed and recommended by guidelines. Now, that is partly probably because the people who avoid long-term treatment probably have milder conditions to begin with. And people who end up on long-term continuous treatment are probably the people with the more severe and more chronic conditions. But there's one study that's tried to control for the underlying condition, tried to look at some of the factors that predict chronicity and severity. And even when they've controlled for those factors, people are still doing better if they avoid long-term continuous treatment. So those studies, they're called naturalistic studies. They can't definitely tell us whether people do better on long-term treatment or do better avoiding it, because they are always confounded, the results are always confused by the underlying condition, the nature of the underlying condition. But they don't provide evidence that antipsychotic treatment is good for people or is the best option. That's why we need randomised control studies, and we need to follow people up long term who've been in those randomised control studies. Because if you randomise people, then you make sure that the people who take long-term medication and the people who don't take long-term medication are not systematically different in terms of the nature of their underlying condition. Long-term antipsychotic treatment causes this neurological problem called tardive dyskinesia, and it's manifested as abnormal sort of little flickering movements, usually in the face. Occasionally it can be more severe and affect the arms and limbs, and it's these abnormal movements that people can't control. And it's been shown that when people stop their antipsychotics, when they develop these symptoms, some people will continue to show the symptoms even though they've stopped the medication. So it seems that whatever's happened in the brain that causes these movements is permanent, is irreversible in some people. And the other important thing about tardive dyskinesia is that the abnormal movements are associated in some people with a degree of decline in cognitive performance, a degree of intellectual impairment. That it's been shown in a number of studies, a large number of studies, that the abnormal movements are associated with cognitive impairment, and in one or two studies that the two develop together. As people get the abnormal movements, you can show that they show cognitive decline. All antipsychotics cause people to put on weight to some degree or another. Some antipsychotics, particularly olanzapine and clozapine, can cause people to put on a lot of weight. It's very dramatic, the weight gain that some people show on these drugs. And the weight gain is due to the fact that the drugs are interfering with the metabolism of glucose and the metabolism of fats. So you can also show that these drugs interfere with glucose, normal glucose processing that happens in the body, and the normal processing of fats. So there's good evidence that antipsychotics are associated with sudden cardiac death. So that is when someone drops down dead out of the blue, and it's found subsequently at post-mortem that it was something to do with the heart. And antipsychotics increase your risk of dropping down dead out of the blue. I don't know how many times, yes, it's about 5 times overall for a normal adult person. It's a very rare, dropping down dead like that is very rare, but it is less rare if you're taking antipsychotics. They are probably associated with increased rates of normal cardiac heart, normal ischemic heart disease, and that may be to do with the fact that they make people put on weight. We're not quite sure about that, and there are other factors that contribute to the fact that people with psychosis and schizophrenia have very high rates of ischemic heart disease, like they smoke a lot, they don't get very much exercise, they're very, very sedentary. So the role of antipsychotics in ischemic heart disease is less certain, but it's probable given what we know about their weight-inducing effects. Antipsychotics were first used and first presented as a treatment for people with psychosis and schizophrenia. So, you know, pretty severe conditions when people really sort of lose touch with reality. But more recently, they have been tested out in depression, and so Seroquel, quetiapine is now licensed for the treatment of depression that hasn't responded to other things. But antipsychotics have always been used for many things that they are not licensed for and have not been properly researched in. So they are given to people with insomnia, anxiety, depression, stress, all sorts of things, usually at lower doses than they're given to people who have diagnoses of schizophrenia and psychosis, but they are nevertheless prescribed to people with other diagnoses. what we now call bipolar disorder used to be called manic depression. And the evidence suggests that what we used to think of as manic depression was a rare condition that probably occurred in less than 1 in 1,000 people. Now, manic depression is when people have manic episodes, when they become very over-aroused, they don't sleep at all, they do crazy things, they're very overactive, and it goes on for at least weeks and often months. And these people usually end up in hospital because it's very dramatic, it's obvious there's something wrong, they're behaving completely differently from usual, and it's sustained over quite a long period. So that is what manic depression is. It then started to be called bipolar disorder, and then ideas started to be put about that maybe there were other forms of bipolar disorder that were less dramatic. So this idea was raised that maybe there was a bipolar 2 disorder, where people had sort of sub-clinical or more minor manic episodes than people who had the more classical form that was then referred to as bipolar 1 disorder. And this allowed the idea of bipolar disorder to be applied to more and more people. And then someone came up with the idea that there was a bipolar spectrum, so that there were also people who had a sort of bipolar type personality. And really that's led to a situation where what bipolar disorder consists of is very confused. The general public probably have a completely different understanding of bipolar disorder than is in the psychiatric textbooks, which is still mainly based on the classical bipolar disorder that used to be called manic depression. But as I say, people in the general public have now come to see bipolar disorder as having sort of mood fluctuations, extreme mood fluctuations. Well, obviously, a lot of us from time to time have extreme fluctuations of mood. We might be more productive one day than we are another day. And so it's if you have this sort of looser concept of bipolar disorder, it's easy to persuade a lot of people that they have it. Now, the drug companies realised this in the 1990s, that this idea of mood instability was something that could expand their market for their drugs enormously. And so a number of companies that have produced antipsychotic drugs have started marketing them specifically to people with bipolar disorder. And part of their marketing campaigns have been to persuade people to consider themselves as having bipolar disorder. So there are now lots and lots of bipolar screening tests that you can get on drug company funded websites, which ask you whether you have extreme fluctuations of mood, whether you're more productive one day than you are another day, whether you veer from being very self-confident one day to feeling very underconfident another day. These screening questionnaires are full of questions that we could all say yes to at one time or another in our lives, and therefore they enable a hugely increased number of people to come under the umbrella of bipolar disorder. So what some of the drug companies that produce antipsychotic drugs have done is they've done tests of their antipsychotics in people with bipolar 1 disorder, either for an episode of acute mania or as an ongoing treatment to prevent relapse. Now, it's not surprising that a drug like an antipsychotic, it's not surprising if a drug like an antipsychotic were found to be useful in people who are acutely manic. These antipsychotics have strong sedative effects, so they're going to slow people down if people are over-aroused and overactive. And then if you continue the medication and take half of the people off and put them on placebo, you'll probably find that those people who go on to placebo have, get a bit speeded up again and have some reaction from coming off the medication. So those are the studies that are the basis for the marketing of antipsychotics for bipolar disorder. But the marketing, so they've been done in people with classical manic depression who are having full-blown manic episodes, but the marketing is very much targeting people who don't have that condition, who may be feeling a bit depressed, maybe on antidepressants, and the marketing is trying to persuade them to see themselves not just as depressed, but as having bipolar disorder. And I don't think that people realise when they start thinking that they may have bipolar disorder, that the drugs they might be given have such serious consequences. And the doses of the drugs that are given for bipolar disorder are quite substantial as well. They're not the sort of small doses that you might get if you had insomnia. So people are being increasingly persuaded to consider themselves as having bipolar disorder by all the pharmaceutical marketing, and then ending up on these toxic drugs that have not been tested for people with more mild forms of bipolar disorder, and yet we know have these really serious adverse effects and complications. There was a story that's very typical written up in the Times newspaper in England by a journalist who worked for the Times, who said that he'd been having a bad patch in his life and he managed to convince himself that he had bipolar disorder. He started reading a lot of stuff on the internet. He was taking some drugs, so he was, up all night on some occasions, so he could easily tick the boxes that said that he had bipolar disorder. He went to his doctor. He said, I think I've got bipolar disorder, I've got this and this symptom. He dressed it all up a bit. So the doctor said, okay, let's put you on this medication. And he said he woke up 2 years later, having been in this fog for 2 years on this medication, and realised that he had never had bipolar disorder. He had had a crisis which was quite understandable in other terms. In normal terms, he'd had a breakup, he was struggling at work, and he'd lost 2 years of his life through being on these strongly sedative substances. I am a psychiatrist. I think antipsychotic drugs can be useful if people are really psychotic, really distressed, really locked up in their own world. The fact that antipsychotics dampen down all the sort of frenetic activity that's going on can sometimes help people to rejoin the real world in that situation. But they are toxic drugs that have really serious complications, especially if you use them for long periods of time. And I think they are overprescribed. We don't give people enough opportunity to try and get off them and see if they could manage without them. And even more worrying, we are now recommending them to more and more people who would not previously have ever thought of taking these sorts of drugs, and whose problems are not the sort of problems that these drugs have been tested in. So people with depression or anxiety or this new expanded concept of bipolar disorder are all getting onto antipsychotics when antipsychotics have not been properly tested in these conditions, and yet we know that they have these really serious adverse effects. So I found out about the real truth about health conferences and the real truth about science conferences a few years ago when I was first invited to come and speak. And they're appealing because you get such an amazing range of speakers. So I just sat through a really interesting talk on the lack of any evidence base for most screening programs, the fact that people are really not informed about the adverse effects of health screening for various conditions. And I've also sat through a fascinating talk on climate change and how the science about climate change can be distorted. So I think the real truth about health conferences are fantastic for getting a wide range of highly respected speakers together who are telling a story that doesn't always get into the mainstream. I think that's what's really important. There are many people trying to do the right thing in the mainstream, but they're still being influenced very heavily by money. So, as far as drugs and for mental health conditions, but also for any health conditions are concerned, the pharmaceutical industry is still very influential. And however many well-meaning doctors and health professionals there are around, they're not necessarily able to counteract that influence. And of course, they come under that influence as well. So this conference is really important to help put to help balance that, to help put the other view out there.